Your work in OCD has done a lot in terms of deep brain stimulation. What is deep brain stimulation? How does it interact with or affect OCD?
So deep brain stimulation involves a neurosurgical procedure. It does involve implanting electrodes on both sides of the brain and the deeper structures of the brain. We reserve deep brain stimulation for people with refractory OCD, so people who have really tried all the standard of care treatments and not responded. So it's definitely not a first-line treatment.
What was your journey in the whole development of OCD in your life and all the way now to treating it?
I've had OCD for as long as I can remember, so since I was a kid. I know there's this thing in the OCD world where a lot of people feel like you should never attribute anything positive to OCD. Like OCD is this terrible, horrible thing. And I agree, it is. I've lived with it. But for me, that is my brain. Like that is what I have known since I was probably 3 years old. For me to feel, reasonable about myself, I have to think that OCD has in some ways contributed to positive aspects of my life and positive things when reined in and when treated.
Are you tired of the endless cycle of your obsessions and compulsions? And do you feel like OCD is ruling your life? Well, listen, you don't have to go on like this forever. As a licensed clinical psychologist with 25 years of OCD treatment experience, I know firsthand how debilitating the condition can be. But I also know that it can be managed with the right treatment. This is why I lead a team of top-tier clinical experts at NOCD. NOCD is an online platform offering specialized, accessible, and convenient OCD treatment. To get started with effective treatment for obsessive-compulsive disorder, head to nocd.com and book a free call with our team to start your treatment journey today. It's time to live the life you deserve and not the life that OCD wants you to live. And don't forget, subscribe to our NOCD YouTube channel so you can stay up to date with our latest podcasts and webinars. Now, on to today's episode. Hello again, everyone, and welcome to another episode of the Get to Know OCD podcast. I'm Dr. Patrick McGrath, the Chief Clinical Officer for NOCD. If you're looking for help for OCD or related conditions, check us out at nocd.com. And if you like our Get to Know OCD podcast, well, you can subscribe on the NOCD YouTube channel. Today, joined by Dr. Rachel Davis. Hi, Rachel.
Hi, thanks for having me.
Well, thank you for coming. And it's always a joy to bring people I personally know onto the podcast and that we get to do this live at the time of the International OCD Foundation Conference is great. So thank you for taking some time away from the conference to come over and have a chat with us.
Of course.
You do a ton of work in the OCD world, and some of that comes from personal things for you and just your love of the professional world that you find yourself in. And I'm just curious, how did you get involved in OCD?
Well, it's interesting. So I have OCD, which I think was always in the background and contributed to my interest. But I think how I first really got into treating OCD is I was in private practice and I had a patient who had OCD and he wasn't interested in medication, partly because of the field that he was in and didn't want the stigma of taking medication. And I realized I didn't really know what to do with him. And so I kind of did some of my own research, and then I found out about the IOCDF BTTI and I signed up for that. And did that, and then felt like I had more skills to treat him. In the meantime, ended up moving to University of Colorado Anschutz, which is where I am now. And the chair at the time let me start an OCD program, and really just went from there.
Wow, that must have been a fun discussion. Hey, I'd like to start an OCD program, right? Or
yeah, it was. He was game. So at the time, our department was really small, and we had very little clinical footprint, and so they were kind of open to building programs.
Mm-hmm. And I'm glad you mentioned the BTTI, the Behavior Therapy Training Institute that the International OCD Foundation puts on. And it's always been a joy to be part of the faculty on that. And are you getting called in now to do some of those lectures at all?
Not the lectures. I do the small group
you
supervisions.
do in the small groups?
Yeah.
Okay, cool.
Yeah.
That's really great. Your work in OCD has done a lot in terms of deep brain stimulation. And that's one thing I'm really interested in talking to you about because it's an area I'm not as familiar with. And so I'm wondering if you can educate us just about what is deep brain stimulation, or DBS, and what does it do and how does it interact with or affect OCD?
Sure. So deep brain stimulation involves a neurosurgical procedure. It's what we call minimally invasive neurosurgical procedure, but it does involve implanting electrodes on both sides of the brain in the deeper structures of the brain. And we target what's called either the anterior limb of the internal capsule or the ventral capsule ventral striatum. And these are areas that are involved in like reward or kind of survival and that sort of thing. And so we put electrodes there, not we, but the neurosurgeon. And then the electrodes are attached to pulse generators in the chest, which are basically the batteries, and then connected by extension wires. So we don't yet have really Wi-Fi capable pulse or electrodes, but and we reserve deep brain stimulation for people with refractory OCD, so people who have really tried all the standard of care treatments and not responded, or responded very minimally. And the reason for that is it is an invasive procedure. It has risks that come along with it, and really we want people to have tried and engaged in, what might work first. Otherwise, so it's definitely not a first-line treatment. And once the electrodes are implanted, it does involve pretty intensive programming. So that's where the patient has to come into my office. The first week we do 3 days in a row, and we have several hours of just trying different settings, setting after setting after setting, to see where they get some relief.
I've described it kind of like you're driving along on the highway, you've got your radio on, your AM radio on, and you go under one of those high tension lines and it goes for like a few seconds. And that's how I've kind of thought about DBS, that you're creating an electrical signal in the brain that's interfering in the brain's already current electrical signal. Is that correct?
Yeah, I think that's a really good analogy. And I think one thing to point out that people don't necessarily realize is that DBON isn't a treatment per se. It's not like ECT or electroconvulsive therapy where you go in and have a treatment. It's something that's always on, except for rare exceptions when you can turn it off. But it's a continuous stimulation that does, and we don't really know exactly how it works, but you're right, it is thought to interrupt abnormal brain communication.
There is, and the joy of getting to talk to a psychiatrist on this, there is a really fascinating look at how we've thought of the brain and what it does, from trephining, when we thought people were, just consumed with evil spirits that were lodged in their brain and we could cut a hole in the top of their head to let the spirits out, to ECT, which at first was really, really significant, and even, where they'd go in and kind of go through and kind of put a pick into the brain. There's so much that has really been refined, especially in the last 20 years. I was wondering, can you kind of describe for people the history of how we've started learning about the brain itself and how OCD works in the brain?
I can try.
As much as possible, yeah.
It's still not entirely clear, but I think I'm really glad you brought up the kind of the almost archaic history. I mean, granted, it's easy to look back and judge what we did, but that's back in the time, 1940s to 1960s, we really didn't have a lot of effective medications, and so people were just doing what they could. Unfortunately, what happened is a lot of people were getting these very kind of gross, destructive brain surgeries that had a lot of impact on personality and functioning in general. And so, that unfortunately contributes to a lot of the stigma around brain surgery today.
Right.
But brain surgery today is very different. We have very strict clinical guidelines, very strict ethical guidelines, and patients are very carefully selective. And the side effects are actually pretty minimal. It doesn't usually affect personality or cause, gross problems. So I think your question was how have we learned about the brain?
That or as we've refined the techniques, what has led to that? Is it medication changes? Is it, obviously we have animal studies that we can use to mimic certain things that you now would look back and think we would not do that to a human or something. But even just like the development of DBS, that comes out of the Parkinson's worlds at first, right? Where we're using it for Parkinson's disease, people stop tremors. And do you have an idea about how they figured maybe that would help OCD too?
Yeah, so interestingly, actually, when they were doing a lot of the somewhat destructive surgeries, they were also doing more targeted surgeries, which included things called capsulotomies or cingulotomies, where they just destroyed small areas of tissue. And actually, it was kind of serendipitously found that that helped OCD.
Okay.
And so that is actually still done at a few centers here in the United States, capsulotomies, cingulotomies, or limbic leucotomies. And lesioning procedures are actually a very reasonable option for refractory OCD. But because we know that those areas of the brain, when it works, when you kind of interrupt abnormal brain signals, that's what's led to people trying deep brain stimulation in those areas. Yeah.
Okay. And you talked about the programming. I've had the chance to program too myself, so it's really kind of interesting to watch as you change that modulation and the pulse rates of the electrical stimulation, what it actually does to just how a person feels, both on mood as well as OCD. I was wondering if you could describe that a little.
Yeah, I mean, it's really almost sci-fi cool. So like the patient has this thing that sits over their chest. It's called a programmer. And then I literally sit across the room with like this tablet that communicates via Bluetooth, and I make changes, and I'm asking the patient, tell me if your mood improves, if your anxiety goes down, or if your energy improves. And you can, if you get in the right spot with the right parameters, you can literally see someone just lighten up, and they get what's called this half smile. So this smile on the opposite side of the brain that you're stimulating. And it's not just a motor movement, it's actually associated with, like, we called it the mirth response, or like people just feel lighter. And it's really the only psychiatric treatment in real time where you can see that dramatic of a response as you're doing something.
Yeah, it's very fulfilling, for sure.
It is.
What do people who have it talk about in terms of how it's changed their lives and what they're able to do?
That's a very good question, because one of the things that's very important for us going into surgery is we have to have people have realistic expectations. And one of the things to think about is that if someone has had OCD that has pervaded their entire life and occupied all their time, if you give them a treatment that is effective and their OCD is gone, they're left with an empty life a lot of the time. And so sometimes it can take people years to actually feel better. Like the OCD is gone, but then they're left facing the fact that they grew up and they didn't get to participate in normal relationships or normal, developmental stuff. And now what do? They're behind their peers. They don't have a job. They're living with their parents. And so, I think that's really important to think about going in. And so we really emphasize the importance of kind of wraparound services. People need to be in therapy. They need to be doing vocational rehab. They need to be doing all sorts of things to help them get back into their lives. That said, I have had a few patients who are highly functional in some areas. So I have a physician patient who's very open about his OCD and his deep brain stimulation story. And because he had a job that he was very good at, his life was not empty. And so he's actually one of our patients who has done better because he had some structure to his life already. Now he still has struggled, with the relationships and figuring out how to have more connections and things like that. We're actually doing some research on quality of life after OCD or after deep brain stimulation. And what we're seeing is it's very gradual improvement.
I think that's really fascinating what you brought up there, this idea that just because we may really address the OCD well doesn't mean that your life just improves automatically, right? Because you have had so much potential time living the life of OCD, you never developed the ability to live your own life or even know how to do that. And I kind of, as you say that, I'm thinking about the movie Shawshank Redemption, when Brooks gets out of jail. He's been in there for his entire life, and he doesn't know what to do. He can't function in the world, right? And it's unfortunate how he ends up. But that just, I never thought of that void before, maybe that some people talk about.
Yeah, and it's really significant. And I think the other important thing that a lot of people don't think about is you still have to do the work. So my same physician patient has described it as DBS is the gym, but I have to work out. He says it's given him the equipment, like it's kind of changed his neurocircuitry, but unless he keeps doing ERP and keeps doing the work, it's probably not going to do much.
Yeah. There isn't that one pill cure, right? I mean, and that is so difficult for people. And I've seen people who still are waiting for that day. And I keep telling them, you're going to be waiting a really long time if that's the case. Yeah.
Yeah, and that's one thing I see in my patients and also experience personally is OCD is, for most people, a chronic disorder, and it's not about curing it, but it's about learning to live with it and still enjoy life.
How have you lived with it? What was your journey in the whole development of OCD in your life and all the way now to treating it? I mean, just it's a fascinating journey, I'm sure.
Yeah, I mean, I've had OCD for as long as I can remember. So since I was a kid, I remember I was scared of everything, nightmares, afraid my parents were going to die. When I was a teenager, I started to worry that I had cancer. And interestingly, I was also interested in becoming a doctor. And so my parents had this like big red family medical journal. And at night, I would sneak up and grab it because I knew it was kind of weird that I was like sitting there memorizing symptom flowcharts. But I would do that. And I'd convince myself I had whatever illness I had. And then before I went to bed, I'd go back upstairs, put the book up, and, come back down. I also had religious scrupulosity, so I grew up Southern Baptist, very religious, evangelical family. And so I had a fear of going to hell, did a lot of compulsive praying, fear of committing blasphemy, even though I don't think I knew what that meant. I just knew that was like the unforgivable sin. So, but I didn't, our family didn't really have a template for calling something mental illness. It just wasn't a thing. Also grew up in rural southeastern Colorado where there's a lot of stigma around mental illness. And so I didn't get treatment. I did undergrad at CU Boulder and just kind of survived. I was very much a perfectionist, and I think you probably talked about, about a third of people with OCD have at least some OCPD. So I had that definite perfectionistic drive. So I graduated in 3 years with a 4.0 GPA, and that wasn't on purpose. It was just because
that was you.
That was me. I thought I was going to fail, and so I was always trying to do things perfectly. But I have to say, college wasn't that enjoyable. And I got into medical school, and my first year of medical school was rough. Whereas in undergrad, I could learn absolutely everything and do things at least close to perfectly. That is just not possible in medical school, like the bulk of material. And so I was completely overwhelmed. I was barely sleeping. And, as a medical student, you don't have much income. So I was living off of very little. And so I got very skinny. I was afraid to eat, partly because I was too anxious to eat, and also because I just didn't want to spend money. And then towards the end of our first year, I just thought I have to either quit medicine or I have to get help. And getting help was like a huge barrier to overcome just because of the shame and the fact that in our family it wasn't really something you talked about. But I was really fortunate. I had, at the time I was still going to church, and there was this woman pastor who was very kind. And we would go on hikes, and she told me about her own daughter who struggled with bipolar disorder. And I thought, well, if her daughter can get help, then maybe it's okay for me to get help. And so, and I really didn't want to stop medicine because I'd wanted to be a doctor since as long as I could remember. And so I reached out to, I don't remember who it was, but one of our leaders on campus, and he connected me to a psychiatrist, and also I found a Christian therapist, and that was an interesting, not helpful experience because at first I convinced myself I could only see a therapist if it was a Christian therapist, because then I wouldn't be going against my religion, and I would still be, doing what was okay. And so I saw her, and she was well-intended, but she did what was called prayer counseling, and I was supposed to just sit there and tell her what God was telling me. And so I literally spent hours just sitting in silence because God wasn't talking audibly to me. And, I'm scrupulous, so I'm not going to make something up.
Right.
So
That would be a lie.
Yeah. So
we don't do
I just
that.
sat there until finally I told my psychiatrist what was happening. And she's like, I can do your therapy too. And so I started seeing her for therapy. I started medication. And that was really probably the major turning point. Fortunately, I responded very well to medication. And it was like one day I'm driving down the street, and it's like the world looked brighter, and I wasn't as anxious. And from there, things just got better, and medical school almost seemed easy. Now, that doesn't mean things have been easy all along. I mean, it didn't get rid of my OCD. It just made me able to survive.
Yeah. And you could have gone anywhere in medical school, but you chose psychiatry.
Yeah, and when I went to medical school, I wanted to go home and be the town doctor, in our
Yeah.
little town of 800 people. But then the longer I was away from there, I realized I didn't really want to go home and be the town doctor. And at the end of medical school, there were really two areas I was deciding between. And one was emergency medicine and one was psychiatry. And I think probably my own experiences with mental health or, OCD did contribute to me going into psychiatry. One, I knew how much my own psychiatrist had helped me and how much that had changed my life. And also the fact that I think psychiatry is an area where there's so much we still don't know. We know how the heart works, right? We know how our blood pressure medications work. We don't really know how our psychiatric medications work. We kind of know, we have ideas. We don't really know how deep brain stimulation works. There's just so much about the brain to learn. And I think that was another area that really attracted me to it.
In all of that, you go over your own fears, your own conditions, and then you challenged yourself, right? You are what we call a living donor.
Yes, a living donor, a living liver donor.
Which is fascinating, actually. Yeah.
Yeah, so that, when I started in my first year of medical school, we had a lecture about liver transplantation. And the instructor told us that actually living donation was a thing, that people could give part of their liver and give it to someone else, and then the donor, their liver would grow back. And the minute I heard that, I thought, that is amazing. I want to do that. And I actually reached out at the time and talked to him. He was the medical director of liver transplant, and he took me seriously, which I was kind of surprised. But then he told me that I would have to have a psychological evaluation, and that kind of freaked me out because that was actually before I got treatment for anything. I'm like, oh, they're going to think I'm really not okay. But anyway, so I kind of put it on the back burner, and then just a few years ago, I was online, I was doing my charting at the end of a long day, and I came across a story on the UC Health website about a woman who was actually a double donor. So she had donated part of her liver to an infant and then a kidney to another child. I think it was a child, it might have been a woman, I don't remember. But, and there was a form to fill out, and I thought, well, okay, I'm gonna fill it out. So I filled it out without really even thinking. Now, at this point, I take a bunch of meds, and I thought they're going to see my list of meds, and they're going to think that we don't want to touch this person. So I followed up the form with just an email to the living donor coordinator, and I said, you're going to see my list of meds. It's going to freak you out, but, I function well. I'm stable, whatnot. I got a call the next day. They scheduled me for all the labs, and next thing you know, I was donating 55% of my liver to someone I didn't know. And for me, that was a huge accomplishment, because I had been so afraid of my body and terrified of getting ill and terrified of bodily sensations, and to be able to go from that to willingly subjecting myself to a major surgery and not even being that scared, just I think was very symbolic of like the progress I've made with OCD, in addition to being a very kind of cool sci-fi thing to do. But,
yeah, it really is. Do you know anything about the donor who received your liver?
Yeah, so my recipient is actually from New Mexico, and I did get to meet her, so it's up to both people whether you want to meet, and she did want to meet me. And so about a month after surgery, they were staying in a hotel since they were from New Mexico. I got to go see her and her husband. And she's Spanish speaking only. I don't speak enough Spanish to communicate well, so I've had the opportunity to actually go visit her in El Paso a couple of times with different friends who speak Spanish and get to know her a little better, and it's been really, really cool.
That's amazing. And the altruistic aspect of that is just so cool too.
Yeah, we're actually, this is a slight tangent, but we're studying altruism and deep brain stimulation for OCD.
Oh, well, okay.
So,
all right, strap in. Let's talk about that.
We're just starting, so we haven't gotten far. But so the target that we very specifically aim for in OCD is actually called the bed nucleus of the striae terminalis, or the BNST. So that's like where we try to put the tip of the electrode. And there's been really just one paper, but it looked at functional MRI activation in the BNST during everyday acts of helping. There's this woman named Abigail Marsh, does all this research on altruism and psychopathy. but that was her paper. And I thought, well, where else are we going to have the opportunity to like stimulate the BNST and then measure altruism? And so we have this protocol, and so far we've only been able to do it with one participant because, not many people have deep brain stimulation, but we're recording everyday acts of helping before deep brain stimulation. And we're also, then we're having them describe like doing acts of altruism. We do personality indexes before and after. And then we also are measuring what's called local field potentials. So with the current electrodes, not only can we stimulate, we can record brain patterns, I guess. They're called local field potentials. But so we have the protocol. We haven't done much with it yet, but it should be super interesting to see if stimulation of the BNST changes anything related to altruism.
I'm interested in your take on this. I've described OCD as an attempt to be altruistic, but in the worst way possible, right? Like, hey, I'm here to protect you. And if you just listen to all of this stuff and do these things, everything will turn out fine. Turns out to be terribly awful advice, but that's how I've sometimes described OCD a little bit to people, like, the hopeful best advice turning out to be probably some of the worst advice, but meaningfully trying to prevent, the ceiling from collapsing, the planes from falling out of the sky, the building from toppling over, something like that.
And you mean like OCD as an entity?
Yeah, as an entity. Yes, as an entity itself.
Yeah, that totally makes sense.
Mm-hmm. Yeah. I find it easier. I don't know if you use that, but I find it easier to describe it that way. Like there's this battle going on in there. Like what OCD is telling you, and do you do it or not? But how does it feel that way internally, or is it different? So
for me, it's different, and I wonder if it's because I've had it for as long as I can remember.
Okay.
And I know there's this thing in the OCD world where a lot of people feel like you should never attribute anything positive to OCD. Like OCD is this terrible, horrible thing, and I agree, it is. I've lived with it, but for me, that is my brain. Like that is what I have known since I was probably 3 years old. Mm-hmm. For me to feel reasonable about myself, I have to think that OCD has in some ways contributed to positive aspects of my life and positive things when reined in and when treated. I think, when OCD is out of control, I'm not spending money, I'm not eating, I'm not, I don't have friends, fine. But when OCD is treated, I do think the same traits that when they're out of control make my life bad actually have helped me be a better doctor because I'm conscientious, I am altruistic, I am very attuned to others' emotions. I don't want to do bad things, I want to help people. And so I think because I have OCD, those things in some ways are heightened when they're effectively treated.
Sure. Yeah. But you're right, run amok.
No,
not the most.
Right. But for me, it's hard to say, OCD is bad. And because it's just so like
because then we're saying your brain is bad, right?
Yeah,
and we don't want to do that. Yeah, no, I always appreciate different perspectives like that. So, what are other anecdotes or stories as a way that you explain? Because you've got a unique position of not only specializing in OCD but having OCD. Mm-hmm. People come in to see you. Maybe you're the first person they've ever talked to about this or opened up to. How do you? What's your pitch to them about how OCD works and this is what it is and here's the goal of what we want to do for treatment?
That's a really good question. What is my pitch? Usually, I don't know that I have a pitch. Usually it's more like people are so relieved to have a name for something.
Okay.
I think that a lot of my work is with health professional students or health professionals, and I've had some really like prominent faculty come in and they just describe what they've been dealing with for their whole life, and they tell me maybe I think I have a touch of OCD, and I'm like, no, you have OCD, and you have severe OCD, and you can see you're really suffering, and I think for a lot of my patients that is just a relief, and it helps them make sense of why their life has been like it is, and it gives them hope that this is something that maybe I can do something about.
Yeah, I love that hope experience, right? That light bulb moment when you give this a name and someone realizes they're not the only person in the world. A colleague of mine calls it terminal uniqueness.
Yes.
Right. That idea that I'm the only person, and I could pull out an OCD book on my shelf and go, "This chapter was not written for you." Right.
Yeah.
It's written because hundreds of thousands of people suffer with this all the time. Mm-hmm.
Yeah, and I do think the ability to accept that what you have is an illness that other people struggle with is an indicator of how likely you are to get better. I think when people struggle with this idea of terminal uniqueness, actually they have a much harder time getting better.
Yeah. Now, this is purely a recall. We didn't talk about this one or anything before, but if I recall, there was a camp you did recently, right? Did you do something out in Colorado where you had folks?
Exposure palooza.
That's
yes.
it. Yes.
Yes.
I wanted that. I couldn't remember the name. So I wanted to talk about exposure palooza and for you to tell everyone about that, what that was like.
Yeah. So this is a brainstorm that the first therapist I hired for the OCD program and I had, we were like, wouldn't it be cool to have a bunch of people come together and we just do like exposures together? And so we thought about this for years, and then COVID happened. And then after COVID, we're like, let's make this happen.
Yeah.
And oh my gosh, the barriers we encountered were amusing and also very frustrating.
No doubt.
We're wanting to do this on a medical campus, and we're telling people we're going to be doing things like making fake vomit, and we're going to, having people like maybe touch sharp objects or be near sharp objects, and just like the alarm that caused. But then, when we met with people and we explained what we were going to do, people, they obviously let us move forward.
Yeah.
But basically, it's this like 4 to 6 hours. I don't remember exactly how long it is. We have some motivational speakers, and then we have just different booths where people can go around and do exposures. And so we have like a bad fortune telling booth where you can get a bad fortune told to you. We have actually someone who comes in and does like some career coaching stuff. We have vomit making booth. We have harm OCD booth. So basically, if name your theme, we have a booth, and it's just been really like the people who have come said it's validating. It has really helped reduce stigma because like here are all these people doing all these like really weird things, and you're getting coaching and getting help, and it's a lot of fun.
Is it adults, children, everybody can
Everybody.
do it? Yeah.
And it's for family, it's for people with OCD, it's for therapists who want to just learn more about OCD.
Is that something you want to continue doing?
Yeah,
Yes.
we did it for our second year last year, and we're in the process of planning our third year. So
I bet it just gets bigger and bigger too.
yeah, yeah. In the first year, it actually happened during the middle of a blizzard, and we still had a decent turnout. So,
Wow.
yeah.
I've been there with having to explain to hospital admins, oh, yes, I'll need a budget for knives and fake vomit and
Yes.
these other things. And they look at you like, what? What are you
Yes.
saying? Or the first time at the hospital when we opened up the program there and we had people sitting in the lobby with a sign on the wall above them that said, please insult me or something like that, just whatever. And I was getting calls, why is this person sitting with a sign? But I'll tell you, after a few months of it, everyone got into it. They loved it, and because they saw the results, which was so great that they could see that they're doing that with someone, which might have felt a little cringy to them on some of the things, was actually helpful to that person to be able to start to live the life they wanted to live.
Yeah, and we have the same thing. We have an IOP, so an intensive outpatient
Sure.
program. And so I am often having to talk to our managers, like, Rachel, there's patients lying on the floor, and this is concerning people. Or do we really need to be doing this? I'm like, yes, we do, actually.
Yes, we do.
So, yeah.
What are you really proud of in the career that you've had so far and excited about for the future?
Well, I love my job. I've gotten to do the most amazing things, and I've gotten to really, I'm in a really supportive department that's really let me pursue what I'm interested in. And I'm just proud that I was able to overcome my fears and the stigma and get treatment, and then that I can make a difference in an area that has affected me personally. But I also think I've actually helped a lot of people, and I'm pretty good at my job, and I'm grateful I get to do it. So.
Is there still stigma, even in the medical community, of the difference between, say, a surgical medical procedure versus a psychiatric kind of procedure? And how do you continue to work on breaking those barriers down?
Yeah, there is stigma, I think, both in the healthcare professionals and then also stigma among, just people in general.
Yeah.
One of the ways that I'm striving to break barriers is, like I said, I have one patient who's very open about his story, and we've done a lot of podcasts and interviews and, write-ups and things like that, which I think has really helped get the word out there. He's had a lot of people reach out to him, and he's been able to support them through the process. So one, I think working with media. Two, just in terms of OCD in general, I'm very open about my experience at this point. I wasn't always, but I am now. And I've also, I don't encourage my patients to be open, but they see that I'm open, and I think that has helped them be more open, especially among healthcare professionals. And I think that's just kind of helps with gradual change.
Are there, for when people come in to see you, do you find that there are still certain subtypes that it's harder for people to talk to, or maybe it takes them a few sessions before they want to open up about versus other ones?
Yeah, I think so. I mean, I think sexual topics or, especially when someone is afraid that they're a pedophile, or anytime someone fears that they're just a bad person, I think it's a lot harder for them to talk about. I mean, people don't usually come in voluntarily talking about like their poop and their pooping habits and obsessions or
how many times they
around
wipe.
That. Right. Yeah. So I try to normalize that by, when I first realized someone has OCD, I just say, now these are some things that happen, and I know they might seem kind of strange, but they happen in OCD. Do they come up with you? And people are often just very relieved that I'm just willing to talk about it.
I'll ask this again, to your level, you're comfortable, but you described coming out of a small town, a highly religious family, and then you go into a field in mental health, which they didn't seem to believe in very much. How do you navigate that and those discussions and the life that you live now that's maybe different than the life you grew up in?
Well, and to add to that, I'm also gay, which in a religious Southern Baptist
just throw that in too.
family,
Yeah, why not?
So
Yeah, we'll just add that. Yeah.
I don't know. How do I navigate that? I mean, I don't go home that often anymore.
Okay.
But my parents, I have a good relationship with them, but we just don't talk about these things. That's how they deal. They don't talk about it. And at this point, I'm okay with it. I'm not going to push things. I have formed my own relationships outside of my family and have different people who are supportive. So I think they do the best they can with what they have, and they understand within the context that they can, and that's that.
And they probably still tell you, we're praying for you all the time, or
they
something?
don't actually. They
not
also
anymore?
don't.
Okay,
yeah,
good.
they're just not. They not only don't talk about things, they're also very much not intrusive.
Okay,
which
good. That's nice.
Yeah.
Because I have seen too how many families will say, cure my child, right? Or just make this go away. And even on when you brought up being gay, there are still in certain cultures, families want to come and say they're just obsessed with boys or girls or trans issues. And if you could just stop it, then they won't be that anymore, and then we can move on with our lives. So,
well, I will say that my dad's initial reaction was to send me a book on healing from homosexuality, which I read, but it wasn't helpful. So, yeah.
Yeah. So there are still interesting cultural pieces and in so many ways, and that presentation of OCD and how it comes through. Mm-hmm. Where do you see the field going, and what excites you about the future in psychiatry?
Well, there's a couple of things, and given that one of my areas of interest is neuromodulation, there's this thing called low-intensity focused ultrasound, or LIFU.
Oh, I've heard of this, but I don't know much about it, so this is exciting.
I don't know a whole lot about it, but it's basically a non-invasive way of targeting the same structures that we target with deep brain stimulation, but it's still all very experimental. It's in the research phase. We're learning about it. It's being studied for things like depression and addiction, and OCD is one of the things it's being studied for. The preliminary data looks pretty fantastic, but data almost always looks pretty fantastic to begin with, so we'll see how it plays out. But it basically involves ultrasound stimulation while someone's fully awake, and it seems like the results are kind of durable. Like they last for, we don't know how long, but they last for a significant period of time. So if that progresses and we learn more about it, that could be a way of modulating brain circuits without having to put electrodes in someone's
And
brain.
all the surgical and the risks
Yeah.
and everything that come with that. That would be fascinating. Do you foresee that as we get into better technologies, that there'd be mobile devices or things you could just wear maybe on the back of your skull or something that could do some of this work? Or?
Yes. And I guess I probably shouldn't talk too much detail about this, but there are companies already looking at different kinds of neurostimulation with kind of mobile
Okay.
devices. So, yeah.
Oh, that's really exciting
Yeah,
to see
it
where
is.
it will go. Any other areas that really you're looking forward to or things that really are on the horizon that's exciting?
Nothing specific. I just love how much we're continuing to learn about the brain and how much it's still evolving. Like, there's still so much we don't know. And to me, that's exciting because it means there's hope and room for better treatments.
I think one of the things I hear about is people get frustrated, right? Because they think we've been looking at the brain for so long. Why don't we know very much about it yet? But it's probably not incorrect to say it's got to be one of the most complex things in the world, right?
Yes. I think it's what we believe defines us as a person, right? It's
Right.
like you can transplant someone's heart. You can't transplant someone's brain.
That's a great point.
Right.
Right.
So,
Or a liver, right?
well, you can transplant someone's liver, yes. Yes.
As you've done. Well, that's fascinating. And tell us a little bit about your work and your clinic and what you do there.
Sure. So I'm medical director of our OCD program, and we have a team of therapists and a team of prescribers. So we offer medication management. We offer individual psychotherapy, ERP ERP for OCD, and we do have therapists who are also specialized in eating disorders and addiction, so we can treat comorbid conditions. We this year just started an intensive outpatient program. Our lead therapist, Emily Hemmendinger, leads that up. And that's going really well. We unfortunately have a wait list out until, I think at this point, it's out until October because we're the only IOP in the region that takes Medicare or Medicaid.
Okay.
And we take other payers as well. And then we have, we do transcranial magnetic stimulation as well. So we have TMS for OCD, which is also another non-invasive neuromodulation technique. And then we have our deep brain stimulation program.
What would be the difference between the ultrasound and TMS in terms of how the modulation works?
So TMS cannot reach as deep as ultrasound. So
Okay.
there are types of TMS that are called deep TMS, and they're more of like a helmet-shaped coil as opposed to like the figure 8. And those can reach deeper in the brain, but still not the deepest structures that we would target with ultrasound.
Understood. Okay.
Yeah.
That makes sense. Yeah. And how would people find you?
Well, if you just Google me, Rachel Davis, MD, CU Anschutz, or University of Colorado Anschutz, ANSCHUTZ, medical campus. You can find our information. So.
Awesome. Well, Rachel, thank you so much for being here with me today. I really appreciate the time and what we've learned. So
Yeah, thanks for having me. I enjoyed talking with you.
Awesome.
Yeah.
And thank you, everyone, for watching us on another episode of the Get to Know OCD podcast. If you like what we talked about today, you can subscribe to our NOCD YouTube channel. And if you're looking for help for OCD or related conditions, check us out at NOCD.com. That's NOCD.com. We'll see you again soon.